Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 189. We have a challenging and a complex coronary intervention today involving several bifurcations. You learn how to handle them, how to intelligently use and interpret imaging. I think it's going to be IVUS in this case today, as well as tips and tricks of performing rotatripsy. With this introduction, let me take you to the cardiac catheterization laboratory where Dr. Kinney and Dr. Sharma are standing by. Samin, good morning.
Yeah, good morning.
Good morning, Anu.
So good morning to our viewers, and we always keep coming with the challenging case, and this is the case with the severe calcification of the branches, few branches actually, D1, D2, and we'll see what we need to do. But has been tremendous input. We still have a lot of demand of the retrograde case. So we are looking for, hopefully next month we'll do a retrograde. With that note, rest of our fellows at present here is Jarmanjit Singh and Tushar, of the 8 international fellows, and nurses, CVTs and imaging, all the usual player. With that note, let's start so that we are on time. This is our accreditation. Knowing that it's the CME event now, not only live as well as the archives, which we have started, and go through the regular process of the CME. These are our faculty, no change from here. And then the next one is the commercial support, is also no change, which have been there all the time. So with that note, our case number 189 is a 69-year-old male who had a class 3 angina and positive stress MPI for multivessel ischemia. So the patient is on end-stage renal disease hemodialysis, has uncontrolled blood pressure, although today is also slightly high, about 160 over 75. Rest of BMI is 25, rest things are good, and basically on good medical therapy. And patient had a cath outside with the extensive 2-vessel calcific disease of the RCA and LAD. And after very high syntax score, so therefore after the initial discussion, patient was brought here for intervention, and I'll show you what it was. So if you say this was the right coronary at that time, look at the calcium. Calcium not only on the right, look at the calcium on the 12 o'clock on the left main LAD, and so very calcific vessels with multiple lesions. The patient underwent rotational atherectomy with a 1.5 bar for 160 seconds, then dilated with a balloon at a non-compliant, and one place needed IVL. Used 8 cycles, finally opened up, and this was the final result. So excellent calcific lesion, which was taken care by multiple strategy of the RotaTripsy with the 3DS, now planned for the bifurcation RotaTripsy. And with that note, Anu will show what we have today. As we always go, the vessel which have been intervened before, we always take the picture, then we'll go to next. People say, why it is necessary? It's not uncommon. I would say like 1 or 2% of the time you start seeing the clot, some plaque prolapse of your PCI vessel, not necessarily the flow limiting, but once we know, we always try to take care of that part first. So this case went through the same process. We did a picture of the right coronary, and you see LV is good. This is the right coronary, still looks fantastic. And now to the where the money is. Look at the calcium. Severe,
The real question here is the left main critical?
And then left main actually looks more now than before. It looks like 30% before, now it's more. And make a comment now. RCA is good, and now the left main. And the LED calcium.
Even if you go to your next picture, you can see here. This is without dye tram track calcium, and this is where your cranial LED picture is. Question is how many branches? Are we going
definitely the D1, although not truly it's a 111, but it's just a little off the bifurcation, very tight lesion, but once you have there, it will involve. Then D2, another definitely involved. So D1, D2, whether you put a stent in both of them, we actually have done. Remember double mini crush? 2 diagonal branches, which we had done as part of the live webcast a few years ago. But this case, I think the D2 is okay. But what we need to do is just work on the D1.
As important a case to demonstrate the role of IVUS, I think, or imaging, whichever you choose, I think, because of some doubt about the left main, I think you'll probably use IVUS.
Yes. What do you have? I was doing the IVUS. So the question is the left main. The left main angiographically earlier was 30-50%. Show the hemodynamics on one side also, please, on the one part of the screen. So on the rota wire, it was changed with the fielder fine cross. We changed to the rota wire, and now IVUS is being done on the rota wire. Okay, make a hemodynamic on one side at the bottom. IVUS may not go. Actually, sorry, I just predicted that and it's boom. Yeah, I would not push it, particularly in the, and that's what my issue always in the rota wire. It gives you very flimsy and not give support. And if you really need to do a IVUS, I would still say you do it on the workhorse wire and then change it to your, because basically is that wire is 0.009, very little support. But anyway, it just showed it that there is a now question based on that. Anu, you want to say the left main is significant, not significant because your IVUS did not go?
No, I don't think we can make a decision on
but
that.
We are ready.
Okay, we haven't opened. We could still go 1575.
Huh? 175, yeah. 175 bar.
Open quickly. I mean, initially I thought 15, but I think we can go 175 bar.
You then focus on. I thought it would be a 152.
You want to get 15? Then let's take the vote.
Okay.
Huh?
15 for me.
Yeah, because we are going to use a IVL anyway. And I say in this day and age, you don't have to be hero. Get a 1.5. Because we know the lower burst size will give rise to a less slow flow, less chances of dissection, perforations, and so may not do the full ablation, but that's okay. Why? Because you are going to combine that with the TRIPSy model with the IVL. So this is completely fine. And as you know, there's a lot of work being done in the IVL space, particularly the laser IVL. The other one is without actually forward-looking IVL, which is there is CTO. They're already starting the trial in the peripheries, and some coronary is starting that CTO, and then put a IVL to make the channel into the CTO area. And there is a new device called Fracture, and will be part of the trial. We just got approval by the FDA for the CMS, and we'll be starting called Fracture trial. Another laser IVL. Mount Sinai will be part of it. I'm in the steering committee, and that so by year end we actually have 3, if not more, IVL catheter available in addition to Shockwave what we have at present.
I mean, I polled the audience unanimously 1.5.
All right, good.
So this is all the education you have been providing them, and I want to also take this opportunity to cite unusual and brilliant feedback note we got. In fact, it went straight to Dr. Sharma from Dr. Saurabh Akstam. I hope I'm pronouncing the last name correct, Saurabh. He's an associate professor at the All India Institute, probably one of India's top training institutions. And he mentioned how he had directly used the lesson from our webcast in one of his recent cases. And Saurabh, thank you for your note, and hopefully you will be joining in today too.
Absolutely. And actually we got a lot of thank email, which one I just shared just this week, all basically saying that how we have one unbiased and the true teaching. And of course, many of these live webcasts and though people go, they have to pay, and we have make it totally complimentary. And not only that, we are giving CME. So we are on top of it.
Why is this not working?
Yeah, it cannot go up. I don't know why.
Battery issues.
Okay. So we continue to do that, our goal, mission, which we started together in 2009. And soon we'll be reaching our 200th case. So we are already to 189. By July will be 192. By June, actually. And then we go. Okay.
I mean, there's a question. This is a 6 or a 7 French?
It's a 7 French because we think that we are going to take care of the may require bifurcation stenting of the D1 with a mini crush. Yeah, good. So always 3 steps. We are ready now to rock and roll.
Very stable hemodynamics.
Yeah.
Another question here is no pacer.
Bring it backwards. Yeah, I mean, in this case, RCA is dominant. I want the burr come back
No. Okay.
in the left main. Okay, good. Okay. Now RCA is dominant. I mean, we don't need.
You saw that,
EF
yeah.
is normal.
Yeah. So you saw that what Anu did basically to pull back to do the distal left main calcified ablation also.
So it was for this area I had a
Yeah.
feeling possibly 1.5 is better. But
Yep. Yeah.
so when you did Samin the RCA, you had used a pacemaker there?
Yes. Yeah, use a pacemaker with the rota burr. All 3 lesions took quite a bit of time. And then proximal segment require IVL, proximal distal segment. Truly the proximal segment, yeah.
Should the patient have significant bradycardia or hypotension here, you'll use aminoflin?
Yes, yes, if need to be, yeah, that is correct. Or first thing I'll do the atropine.
Atropine, yeah.
Yeah, first the atropine, and but yes, if continues to be a bradycardia, consistent bradycardia, then aminoflin 300 milligram IV.
So
and that's what we are teaching everybody, particularly with the radial. When you don't want to go with the venous point, if you are going to the groin, just put a pacemaker. If you are not using the femoral artery, then femoral vein, so you want to avoid it. So giving aminoflin and atropine is a good combination.
I think it was a good idea for the 1.5 there.
Yeah.
I think will come out.
No, it didn't go out. Wow. Okay.
We've done majority of it. I think nothing wrong in coming out because we're seeing some EKG changes.
A little bit. So
time.
other question is 2 things. One, as mentioned, that you don't have to have a full ablation. Your partial ablation is good enough.
So the time.
And the second basically is that you can go with a higher speed. Because we are 145, you can go to 160 because ablation efficiency goes down at the lower speed. It is better in terms of slow flow perforations and low, but ablation efficiency goes down. And that is where David Oth came, that any burr less than 2, your ideal speed is 180 or 160 to 180. And of course, once you go to the bigger burr, then you go to 150, 160. But we are starting with the 145. So if you want one, yeah.
Go. Sorry, Samin, go ahead.
No, that's fine. So we are just going to increase.
Definitely, absolutely not worth the cost of a 125.
Yeah, that's right. Yeah. 160. Yeah. Yeah. Good. Good. Now polish.
Okay, recross it.
Yeah. Yeah.
So this was done with the higher speed?
Yeah, 160. Yes.
Okay. So very important lesson for people watching the situation where the ideal burr is not crossing, and how do you modify the speed as what we did in this particular case. Yeah. Already applause for having explained this technique and the rationale behind doing it. Thank you all and continue to follow as we possibly take the next step. We'll help you with the imaging guidance and the decision whether there is
the D1
additional rota for lithotripsy here.
1.5.
Huh?
Yeah, we'll do it.
No, then why you want to run through wire here?
No. You too.
Huh?
So yeah. So let's
stop it.
Yeah, good. Let's take a picture and then we go to the D1. Yeah. And I think clearly the 1.5 was a very good choice. Yeah. So now if we have to put a wire into the, it's very tough to move the wire once it is there. So we have to take that
No, do
out.
we use the same 1.5 bar?
Yeah, 1.5 bar is okay for D1. Big vessel, short lesion. So let's try. So key is your wire has to come out from the burr. Otherwise it does not move. Very important.
Just amazing. I was wondering, it would be a struggle to get the wire through, and there you are.
Yeah.
Excellent job, Anu.
Yeah. So same points, of course, expertise is there, but basically is don't leave the wire in your burr and then try to move the wire is impossible. So you take out, that's what we did, and now we are ready for same 1.5 bar. And I can tell you these speed numbers of 160, 180, 200, which David Author came up by his bone experiment in his garage.
Can you take a picture? So
Okay.
we see the distal edge.
Okay.
Don't give diet. Let us see on cine first. Okay, go.
Yeah.
Okay.
You just pull the wire back.
Yeah.
We can go to cranial view.
No, I don't want
Or,
cranial view.
or into the other vessel, the bigger
Yeah,
branch.
that's fine. Yeah, bigger branch, the lower one. And we have enough room there.
No, you want to, yeah. Since it's a branching diagonal, you got to be sure which way the burr is going to go when it exits. So
Yeah. Good.
I think it may be that this branch is, okay, let's just
see. 1 second.
It's on the top branch.
Yeah.
Let's
Select
here
it.
it has to make
Should
a
be
turn.
able to, yeah.
You want me to take this bar out?
No, let's go.
You want a
Take this,
clip? And use the clip as a torquer if you need, no? You're
Still
good?
on the top one,
Okay.
no?
Okay.
It's okay.
Yeah,
I
but
think we
remember
know.
the-
I think we just have to take care of that lesion. That's it.
Lesion up to 1 second off fluoro.
No,
You
I did not
think
go on fluoro.
the ostium also has a significant lesion?
Yeah. Yeah. So we have enough room up to 1 o'clock only. Okay. While we are doing this,
You
I
want to
just
go cranial view, you're saying?
yeah, cranial. Just go back to cranial. Yeah. Yeah.
15,
Same view.
34.
It's a little dissection in the proximal part of the
Let's see.
LAD, but doesn't
1
look to
second.
be
Let's see. 1
involving
second.
the flow.
Where?
And now
Right on
people
the
may
superior-
say,
superior-
yeah.
Yeah.
People may say why we should do this means why you have to remove the wire of the LAD and go to the side branch. We can do IVL. Yes, that's also another choice,
Okay.
right?
Yeah. That is true. But so
Oh,
I mean,
wire,
yeah,
hold
good,
it.
Good. Yeah. Hold it. Yeah. Good.
No, wire.
Mhm.
Pull back.
That's good. That's a
No,
clip.
no, pull back.
Mhm.
This time.
As you see that once you go to the side branch, push and pull is a little more materialistic. Sometimes it will make a curve, I mean loop, but I think we are going okay.
No, loop is worse than a single
Yeah.
because
Good. Yeah, good. Okay. We are back here for the D1 now. As you can see, same 1.5 bar. Okay, good. We always want to avoid any.
That's that ostial lesion, and
Yeah.
you crossed it just now. That's fantastic technique.
20-second run, always watching the blood pressure, and then you see the drop in RPM. If it is a 5,000, comes a empty, the blue color or yellow, and if it's more than 10,000, then it becomes a solid yellow triangle. That means you're too fast. You have to cut down slow. The same thing. So much calcium,
Yeah.
and
going
then
to the distal.
speed dependent. Yeah.
should we go 1 to 5?
No, let's take a picture. You want to take? I think you have very short lesion. You want me to take one picture?
Could be wire bias.
Yeah. Let's see.
I don't like the feel of that burr there.
No, but there had not been much drop in RPM, which is okay right
It
now.
doesn't matter the
So-
wire bias.
Yeah. Yeah.
It's a superior surface.
And you go to 160. This
No, 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 no,
likes
no, no.
160.
55,
Good. Done.
Yeah, probably.
Yeah.
Okay, come out.
Excellent.
Yeah.
And this
Make
was
a
done
3
without,
ideal
Get the run through wire.
Yeah.
without increasing to 160. This was done at 150.
So 152. Yeah. So exactly.
What made you convinced that you could safely proceed with it?
Because there was not drop in RPM.
Right.
Once you have a lot of resistance, there will be
Right,
for 1 minute, for 2 seconds, the empty triangle came, the yellow triangle. It never was if it becomes full, that means it's a very bad situation, and your drop in RPM associated with a higher slow flow, higher spasm, and therefore that did not happen in this particular case. So therefore we said let's keep going. But yes, at one point, let's take a picture now.
Yeah, that would be very useful to see how that second lesion looks now.
Yeah, good.
Okay. Angiographically, you can't make out, but you had definitely crossed that region, and I think we'll know it with the ease with which the balloon inflates.
That is correct. Yes. And that is also happened that I tell people that don't look at that you had really modified the lesion once you are using a small burr.
Angiographically.
Yeah, angiographically. Because basically what you did is you just created a crack in the calcium. And that is what hopefully will show by the IVUS in this particular case. So that crack in the calcium is the what you want. That's okay. Go to diagonal and we'll go to the where is the fielder wire we have? Go to the LED. Yeah. So that's all we need because crack. That's our goal is and crack in the calcium basically. 3.
We need to see the machine. Bring it this way. Yeah.
Good. You want to see a little die? No, it's okay. Good.
Okay, excellent job again.
So this
with
is the run-through wire being advanced into the LED.
You know, the first diagonal is a very large branch.
Oh, very large branch, yes. And D2 is still maintained, so that's the good news. Okay. This is your fielder wire for the diagonal.
What size burr? I mean, what size you took IVL?
No, just that's okay. 3. Yeah. Good.
I mean,
Yeah, good.
without
We'll decide.
imaging.
Yeah, we'll decide based on the imaging.
Yep.
So now we are doing, let's see here. The diagonal is okay. D2, everything remained fine. Yeah.
So you would be using the IVL mainly for the mid portion of the
Middle
LED?
of the LED. Yeah, that's exactly correct. Yes. Now we are putting the fielder wire into the diagonal. A little die. It's a big branching diagonal. I think you have to pull back a little bit. Okay. Yeah, this is that. Now
We have it in the right branch, finally.
Right branch, yes.
You know, it's quite possible that slight lesion modification with the rotablator cleared the channel going towards the lower branch little.
Yeah. Yes.
But either way, that's the more stable branch.
Yep.
You get me the IVUS?
Okay. Let's get the IVUS now. So we now doing the IVUS of the diagonal or LED?
LED.
LED first. Okay. So IVUS of the LED. Let's see this.
Slight dampening of the pressure. I still go back to that left main as if there is something.
Could be. Yeah. If it is, then you bring it up to the mid portion. Okay. We are ready. Let's bring the IVUS. Yeah.
Anu, a lot of compliments here for your rotablation for both the branches.
Thank you. Now we are
Okay,
going.
now I was going.
Lot of so many practical tips, and I think now it is kiski time, and
Guide out a little bit.
we
Guide
learn
out.
how to be
Yeah, there it is
better.
out. Okay,
Yeah.
start pullback. It's coming.
Yeah.
It's a mid LAD. Yeah, already
A lot of
360 calcium.
calcification still.
Circle,
Yeah,
360
yeah.
degree.
And,
Look at that.
wow, very tight 360 calcium. Yeah, now come to the proximal and the left main. Yeah, left main has huge calcified nodule. I will stop it.
Okay.
So I will show you first the left main. This is the level of the aorta. So this is a proximal left main.
Oh.
Yeah.
Yeah, that's where it was getting caught in the first.
Yeah, IVS didn't close maybe because of this nodule. Yeah, and a very tight, like area is 4.8, less than 6, even after the loader. Yeah, and a proximal LAD looks no major fracture, so I think it's good idea to go IVL.
But
Absolutely.
any cuts, my question is, any cuts you see in that circle?
You,
I mean,
circular
you
calcium.
do actually.
It might be here,
Yeah.
but I also see the no
even at 1
fracture
o'clock
parts.
position.
But at few places there is not even a single cut, right?
Yeah,
The
few
full
places have
circle.
something,
Yeah.
some cut, but I also see
Maybe it has just thinned it because
No,
of small
no,
bar.
no. Yeah, it is a small bar. It hasn't reached. This is where are we? Proximal LAD, right?
Yeah, this is a proximal to mid.
Yeah,
part.
look at the diameter.
Yeah, lumen is like a
2. So
2.0,
one
so
fiber
it
did
is-
not even touch it.
exactly.
No, but it will touch in
1,
the
2,
eccentric
3.
area. Remember, it doesn't have to be 1-to-1 lumen. But anyway, what's the plan now? The question is always that we have done IVL caused
Show me
more
the-
cracks compared to any of the atherectomy techniques. Just to say, the randomized trial of the target 3 showed that expansion is equal both, but from cut point of view, IVL causes more fracture in the calcium compared to atherectomy.
So show me the distal LAD.
Yeah, so this is the start of the pullback. Still like a 90-degree calcium. Vessel size is 3.5, but lumen is
Yeah.
like a 2.7. Maybe 3 or stand. And the lesion length from here to the ostial left main is 60 millimeters. So
How much?
60.
60.
60.
Okay.
So if we-
show
if
me
we-
the diameter of the where the lesion thing is. You need
Sure.
3.5. If you have to do
No.
IVL, has
no,
to
no,
be
no,
3.5.
mid is 3.0. Mid is 3.0 LED, right? What is the size of the LED in the mid area?
3.21.
yeah, I mean, if we want a EL to EL, it's gonna be 3.5. But tightest part, the MLD is like here is lumen is like 1.5, the tightest part, like mid LED.
Yeah. So we have a 3.0 IVL and
Based on the imaging, okay, from if you are going from distal LAD coming all the way to proximal and you want to deliver your 12 right cycle pulse, you should go 3.5.
only question is that our goal, biggest goal here is to the mid area, which is the tightest, right? So 3.5 will not be big there.
No,
Connect.
this is what we are to be learning. That's why imaging is so crucial before you select the IVL balloon.
Sounds good.
What do you think, Iski?
Yeah. So if so up to the doctor. So if you want 1-to-1 ratio, 3.5. But
And,
tightest part is very tight, so 3.0 is I think
Since
enough
Rota did not do a lot in that proximal area and 1-to-1 you need, then it had to be 3.5.
Okay.
Anyway,
You want to do
let's
it
go
here
here.
now?
No, then it will not go distally.
No, but
Not
there is a
even-
calcium nodule preventing this further growth. Let's do it now. Here.
Okay, it will not go further.
Yeah,
after
but that's
that
fine.
Once you
Yeah.
open.
Okay, we are going to the 6 atmosphere here. So remember, you can go IVLs up to 6, and then before ending, you go to 8. So this is that calcific nodule preventing the further progress.
No, that calcific nodule is in ostial.
No, distal left main. It's a distal left main.
No, ostial left main.
It is an ostial left main or distal?
Like osteo to the mid part of the left main.
Mid part of the left main. This is just the way the wire bias is in that LAD. That's
Okay,
it.
let's do it
Nothing
again.
to do
Yeah.
with it.
We have other non-compliant balloon also.
Now
That's what we
nothing
need.
is going to go.
Yeah, let's do it here. One
Show
more.
me the ostial LAD, Kiski.
Osteo, sure.
Okay,
So
let's do one more.
this is
And
the
then otherwise we go to
bifurcation
high pressure
from the
balloon.
1
We have
o'clock.
high pressure.
Yeah.
Okay, down.
So this is a osteo LAD, like
Yeah.
270 calcium.
Okay, down. Maybe then you know what? Let's go with this to the diag. We do the diag.
No, but you're
that's
not
it.
even going beyond the left main.
It may go into the diag. This is just the way it is. Now, you really want this down, we'll have to do a fielder in the LAD and go on the fielder wire.
Okay, so let's go a little more here. Yeah,
It's not.
you come back into the guide and go now. Again, try. Okay, this out. No good. Take it out. Yeah. So now
Get me a fielder wire quickly.
you want one more fielder? Okay.
I know
I
what
know
can you
this
do.
was a 3-5 or 3-0.
Trio.
Trio.
It's a trio.
So 3-5 would have been totally.
No, no,
ambitious.
it's not. No. I think means 3-0. It's the deliverability balloon has nothing to do with the diameter of the balloon. It is just that's where
Yeah.
even the eye was we were having issues.
Eccentric calcification.
Yeah. So let us try on this one. If it does not work, then we go to the diag. Otherwise, we are ready. We took a 3-0 balloon, right?
Yep.
But then the left main will need 3-5. Usually we don't put 3 wires, but we are going to do that just to see if the IVL can be delivered.
Would
And
you
also a
use,
nice teaching point to say if somebody has said, okay, why don't we directly go IVL here, right? You can't even get the balloon across.
Yeah. Yeah. So, I mean, that's one of the limitation of the current IVL balloon, and those are the new ones. They are basically focusing on this aspect, is that how can we crossability profile. Okay. So let's try the same IVL again.
Yes.
Okay. Now we are going on the fielder wire.
Fielder wire of the LAD.
Yeah.
ACT is good? Okay.
And patient
Samin,
received Angiomax. What is on? Heparin. Okay.
Would a
Yeah.
guideliner be too aggressive?
No, but that's okay. Only problem guideliner will be with a double wire. You
wires,
cannot
two
go
wires
just
there,
at
yeah.
the level of the diagonal. Remember, you cannot go beyond the diagonal. So this one, no, I would say just go with the high pressure. There's nothing wrong in that. That high pressure, make a room for, that is 54% even in the disrupt CAD 3, which was not that complex. They use a 54% time. They had to do a pre-dilatation. So this is nothing wrong in that point, in this particular case. I'll just go with the balloon which we have.
You know, in real life situations, I can tell you it's probably even more than that 54%.
Yeah, exactly. That's what I meant. That in the disrupt CAD 3 was
Constantly, you need
54.
to-
Yeah. Good. Get a balloon. That's one we have. Yeah.
3-0?
Yeah. Yeah, we are 3-0 right now. Yeah. And that is okay. People say, well, after you did a balloon, you have probably removed the efficacy of the IVL catheter. No. Because IVL catheter is, this is just giving you the lumen. IVL catheter is going to cause nice fractures in the plaque, which balloon does, but not that much. Yeah. You want to take that one wire out? I think fielder wire is no good. NG. We can remove the fielder wire. Okay. So we are going back to our run through in the main vessel. Two wires came out.
No. Yeah, we have the run through there.
Okay. So this is the fielder. So we are going with the trio 20 millimeter non-compliant balloon. Make a little room. So key is that a balloon in pre or post IVL does not alter or efficacy or neutralize the efficacy of your IVL. That's one point we want to make. And even post, some people after IVL, they will go direct with the stenting. Many of them in the calcific lesion like this, even after IVL, I would still go with the high pressure balloon, open the lumen before you stent it.
Okay. I think we needed that.
Now, the only question is it the diagonal wire creating some crisscrossing?
No, I
No?
don't think there's crisscrossing there.
Okay, then what do you want to do? I would say
No.
take the diagonal wire out, try to see the diagonal wire go into the LAD, go into the LAD and then to rewire the diagonal. Unless you want
Give
to
me
get a compliant balloon.
get me a compliant balloon.
Okay, 2.5?
Yeah, get us a 2.512 compliant balloon.
2.5 or 3.0? Okay.
3.0 we don't carry compliant 12. You have? Okay, give me.
Yeah, 3 or 12 will be okay. Do you want to go to the diagonal first?
I just focus on that.
Like to welcome a person who's just joined us from Trinidad. Not sure if I have spoken to him before. Naveen Sicharan.
Hmm.
Naveen, welcome from the
Welcome.
land of Brian Lara,
Yes.
who's playing cricket at the moment in India
Ah.
at the age of 52 or 53.
Okay, let's go up here first. Okay.
I
Could
think
have,
also, okay, go up here.
Yeah.
What exact?
Anu, go ahead.
No, I was just thinking double wire. We should not
No, I think
remove
it's
the
just,
double
it will
wire.
go now. Yeah. So question was, could it be a crisscross of the diagonal and LED wire? That's one.
No.
Secondly, it was just such a tight lesion. You
No,
needed
it was
to have.
not tight lesion. If you go with the, if you see the IVUS, it was just the wire bias.
Yeah. Ruptured. Balloon ruptured.
Now at the ostial proximal LAD, is there a nodule?
Non-compliant now.
Nodule is just in the left main.
Nothing in the
LAD
LAD.
has a calcium plate.
Ostium to mid portion.
Yes, of the left main.
Okay. Now we go with the non-compliant balloon, which we had earlier.
Don't connect yet.
We have one more interferer. Good. Yeah.
Why did it move to the top?
Which one?
Things changed upside down. This is gone.
Yeah, I know.
Good.
Good.
Okay,
Good.
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 Okay.
Yeah. Okay. Now our 3.5, 3020 non-compliant has gone. And doing the mid LAD first.
I think this is possibly the game changer of the whole case. I think
Get the IVL again.
Yeah. Pull back a little bit. Yeah. Good.
so.
I would
Samin,
put a short
here is,
stent in the tag. No
there is a
bifurcation.
very important feedback for you and
Okay,
relevant
good. It opened
information.
up.
Yes.
Opened up.
So this is Naveen Sicharan. He's I'm going to read it exactly what he's
Done.
written. That is absolutely correct. Our local living legend. He's talking about Brian Lara. And then he says, by the way, I referred some of my chip cases to you guys.
Yep, that's right.
All with amazing results.
Yep.
So wonderful.
We just recently, our last month,
Okay. Done.
very complex right coronary, requires 2 rota bar, 2 IVL, very tough
he
one.
wasn't going to be sending you a simple case.
Because simple, we want him to take care.
Go.
Ready?
Very good, Naveen. I'm based in Miami, and for years we did that.
Down.
Trained many hospitals in the Caribbean and got them started, but they used to refer the
Get the
complex
IVUS quickly.
cases there. But amazing progress in Trinidad as well as in other Caribbean islands. And I wouldn't be surprised that the patients, the chip patients you've been referring to Dr. Sharma were Indians, with their diffuse coronary artery disease and calcifications.
That is correct.
Kiski, I'm going to do a quick IVUS. So after balloon, we can see what has happened. Okay.
Sure.
Meanwhile, can you show that app
this
slides, Yulia, without means we didn't do IVUS before. So angiographic, okay?
A slightly humorous touch to the conversation regarding Trinidad. So Naveen, one of my patients helped me understand Trinidad. He says everybody from Trinidad is so hardworking. Nobody has one
Okay,
job.
show me.
Can you show the IVUS on the screen?
Okay, good.
So it's a 360 calcium pad. Okay, I'll start pullback.
Yes.
Still there.
Yeah, I see some small fractures. Yep.
Hmm.
Yeah, there's a fractures. Definitely different from the initial pullback. Yeah. Now come to left main. Yeah. Nodule still, of course, there.
Okay, the tightest area, right?
Yep.
We did a trio.
Yep.
Now you tell me what happened, right?
I mean, okay.
The diag
It
wire
was
has
before
come out.
like nothing fracture, but now like slight fracture, like 3 o'clock and
Flush,
7
flush.
o'clock, and the lumen is bigger, but still 360 tight lesion.
It is
in the-
there.
Yeah,
What's the diameter there? 1, 2, 3. Right. Get the IVL. Let me go with IVL there.
if you want MLD, it's still 2.0. But we see some fractures.
And the vessel size there, Kiski, where you had the
So-
195?
Of course, we don't see the year because of the 360 calcium artifact, but from the initial pullback, the vessel size is 3.5. Yeah. So by IVL, a lot of fracture there, but still a lot of calcium still there. And the left main, still nodule sticking into the lumen.
Left main nodule is still there.
Yes.
IVL didn't do anything. Too small.
Sure, but by
Yeah.
iris,
But you
not
didn't really
sure.
put the IVL there. You were more
No,
distally.
we did. Yeah, not
I thought
ostial
you were
left
distal,
main.
yeah.
It
Mid
might
to
modify.
distal left main.
You were
Okay.
more in the ostium of the LAD.
But see, we wanted 3.5, 3.0, so your waves are not reaching, I think. Okay.
Yeah,
Now
let's
we'll
show
go to the
angina.
tightest part of the LAD, okay? And then I guess I want to put a short stent in the diag, not do bifurcation. Okay. It's not going still. Still not going. Not be aggressive, right? Yeah, okay. No, those are the app definition. Okay, go up here. Those are the app slides that we use calcific app to say what we can do. Go. So now we are going with the IVL. A little bit more. No, we did not. No, it's not going still. I'm trying. Okay, done. No, it does not inch easily. No. Okay, go up here. Go.
So that actually, as I said,
Go.
that was a down part of downside of the 1.5 bar. That it did go. It was tough, but it has really, as Anup mentioned earlier, also has not done much to the plaque. So therefore, so it's always a trade-off.
Absolutely.
Yeah. So clearly was that yes, it looked like at that point 1.5 was okay, but we are struggling
Okay,
because
go
of
now.
1.5.
Yes.
And we know that
Safe.
1.75 would have been could have been the totally different story.
No.
A safer choice, but inadequate ablation.
Yeah.
No, I think what I'm saying is when IVL did not go, should we have gone 175 bar?
Okay.
Yeah, but
Upgrade
that
also.
is what
Upgrade at
I
that
think
time.
Samin was
Yeah,
indicating.
Also. Yeah. Okay. So let's see now.
Okay,
It'll go
up
now.
here.
It'll go slowly and slowly, inching through.
Okay, go up now.
So go 6 and then 8 there. 1 sec.
I think diag SS, let us just do a short stent.
Okay. That distally.
Yeah.
We need a balloon, 3 or 12 balloon. We are compliant, but we need a non-compliant.
Get me the other new finger wire. Okay.
The trackability of the IVL catheters is still a challenge, really.
That's good.
Yes.
Yeah.
Okay, go up here.
Yeah.
I mean, something which you used a high pressure balloon, one would have thought this would.
Okay, down. Think we're good, right?
Let's do one more and boom.
Not going.
Okay, just leave it there. Go. 6.
Want to try the diag or leave it?
No, diag we can have just high balloon, 3 or 12.
Okay, down. Get us a high pressure balloon. No, no, we had, right? A high pressure
No,
balloon.
we do not have, but we are 20. Go to
Okay,
6.
down.
Yeah, and down. Okay.
Anu, I think without our addressing it, you've been demonstrating a very important aspect of dealing with complex cases. You know, the lesion will turn out to be more difficult. Devices may or may not necessarily. So keep modifying the technique, always keeping the safety of the patient in mind.
Underneath, which one?
Yeah, no, I'm going to go with the fielder to the diag. The question you're saying, don't try the IVL in the diag?
Oh, so okay. We can try the IVL in the
Let
diag.
us
We
see.
have enough room. Yeah.
If it goes,
Yep.
otherwise
Yeah.
we just go balloon.
Yep.
Now the thing is, you know, that mid LAD lesion is opened up.
Yep.
Are we happy with it?
Or other question is, do you use a cutting balloon?
Yeah, that's what I'm thinking. But you have to go 3 to 5.
3 to 5 cutting balloon.
Hold on, Kiski.
Yes.
That cutting, I mean, you know, the mid LAD we IVUSed after a high pressure. You think we are happy with that?
Yeah, there is some small fractures.
The calcium plate
but still tight. So.
that has been cracked.
You want to try here? Remaining.
Okay, let's try the IVL here.
Okay.
Does not go, then we are
back.
done. This is the last.
Yeah. Rotatripsy of LAD diagonals. Haha.
No, so now the only thing is that one thing that we could have is that as soon as we knew
that IVL did not go with the 1.25 bar. I mean
go
1.75
negative
bar.
with the not like way, with the
Yeah.
with the syringe.
Yeah. Okay.
Does the profile of the IVL catheter become even a bigger challenge when reintroducing?
Yeah. I mean, so the deflated always is the issue.
It's never.
And then bigger the catheter, 3.5 would have been even big trouble. The profile is higher. Okay.
I won't say that. I think maybe 3.5 in the proximal LAD would have allowed us to. Okay, forget about it.
Yeah.
I will not even waste my time.
Good.
Okay.
Experiment is over.
Yeah. Experiment is over. We get 3O balloon.
We have no 3O or 20 we have.
Yeah,
Okay, then a shorter, right? We don't want to 20
We
there.
wanted 12, right?
Yeah,
We wanted
3 or 12. High pressure.
Yeah.
Let us put a short stent in the diag, and then you have to make a decision. Do we stent up to the left main? What was the MSA at the left main, Kiski?
It was like 4.9, the initial one, MLA. It was
Okay,
tight.
that is another. Okay, so then we put a stent. What less stent you want? They were what stent?
Nine.
Okay, let's get 18, right?
Huh? Synergy, right?
No, so Zines.
No. Yeah.
Okay.
It was Zines, yeah. Yep. Yeah, 3O.
That is what you had used
48?
for the RCA.
Yeah. Yep. 48. Let's go. Good.
We put 18.
Yeah.
Go.
Good. 3O18.
That opened nicely.
Down. Then you said 60 millimeters, right? So
And
then
we
you
use
want
two
to put a
separate.
3O.
3O 38 and then maybe 3.5.
Remember at the level of the diag, we have to be
in between. Yeah.
Yeah,
That's
so
fine.
let
Between
us
two
make
diagonal.
first
Yeah, that's
diag.
fine.
So make us 33.
Yeah.
Yeah.
Pull back a little bit more. No. Yeah.
33. Okay. 3O 33.
Okay.
Okay, good. Down. I'm not doing bifurcation here. Down.
Why?
No, we're not doing mini crush.
Okay.
Leave it.
Let's take a
Nothing is
picture.
expanded here. Okay, go.
Okay,
Ready.
we are taking one picture now after a long time.
Good.
No, but look at the diagonal. You need to come up to the ostium.
Thing is, there's so much of under expansion, calcium is not fully, and you don't want to put a two stent.
The question is that do we come up to the ostium of the diagonal or not? So that's where the question now is. That do we make a mini cross or just put a stent in the diagonal? Yeah, let's see, this is the picture. Although it looks okay at the ostium, but I think come up to the ostium. We are ready with the two stents. Actually, first put one stent anyway. 3033 in the main LAD. Go. Yeah. Yeah. Gloves.
Get the IVUS of the for the diag.
You know, the flow in the LAD has not looked this good. You know, it's looking, I think, a little more diligence here, and you'll have an outstanding result. My mind keeps going back as to how
Stent.
the left main will be addressed.
So I'm going 3033 to the LAD. We are going to IVUS the diag because I do not want to do bifurcation stenting since our calcific modification was not the best. I'm worried about stent under expansion. Okay, some dye. Okay, take a picture. Ready?
Kiski, a question for you. You're using the Boston Scientific system?
Yes.
Yes.
This definitely like a 60
So
megahertz.
Gayan, that is your answer.
Okay,
60
go.
megahertz IVUS from Boston Scientific.
Yeah, and
Go.
AI integrated Avigo Plus.
Go. Avigo plus.
Yes, with
16.
like a first pullback. Max
Okay,
speed
down.
is 8 millimeter per
Go
second.
up again.
Very time saving.
Before IVL days, we would have done 2 bar rota of the LAD, balloons, cutting balloon. Ready? Right? So I think, Samir, what we have learned in this case is if IVL had not, once the first time it did not make a turn, I guess at that time, we should have just decided upsize the bar.
Absolutely.
Yeah.
Slight, you may be wanting to put a short balloon for a slight dilatation post stent, that area.
I don't know, we can, but that area, remember, we could never get anything. No, yeah, the IVUS. Quick. We are going to the diag, Kiski.
Sure.
For flush. So plan is 3018 to the diag. That is EYE IVUS. That's the new IVUS. Yeah.
Not a longer one?
Oh, you want longer? No, because plan is not to cover the ostium, not mini crush. Spot stenting of the diag.
A sudden, this is,
Go,
I've not noticed
Okay, check the image.
something like
Okay,
this
I will start to
before.
work.
Go.
Okay, this is a good landing zone.
A spurt of
Exchange
viewers have
clock.
just joined us.
Ostium I need. Okay.
Wow, tricky image. Okay, I will stop it. 1 second. Yeah, anyways, vessel size is like a 3.3, so I think 3.0 is a good one. And this is after the rotor IVL. No. Rotor.
IVL did not go.
Yeah.
Flush.
So there's some intimal
Ostium.
dissection. One second. Looks. Yeah, this is ostium.
Yeah, that's a tight area. I think that's nice. Ostium is good.
Yeah. So. Yeah, it's true. It's AI integrated, but not sometimes not correct. So I need to edit something. Yeah, actually area-wise, it's like 3 point something. The osteo D1 270 calcium, not wide open.
Huh?
Osteo diag is area-wise, it's 3.3. And the mid portion is still a lot of calcium with some nodule. Mid part of the diag.
But we have done the balloon there. Did it open up or no?
So I'll show you. So this is the tightest part of the mid part of the diag. Yeah, still area-wise it's 2.0, but some like intimal dissection between the calcium and the plaque.
Okay.
If you think balloon expanded, maybe we can put a stent.
I don't want to go cutting balloon again. So you're saying come up to the ostium?
Yeah, area-wise it's tight.
In the meantime, like to welcome Dr. Gayan Kanchana from the Kettering General Hospital in the UK. And
So show me the
originally
ostium
from
of the LAD,
Sri Lanka.
left main. Ostium of the left main.
Left main.
Yeah, quick.
Sure. So I come back to the initial pullback. So body has nodule. So this is the ostium, level of the aorta. So yeah, here, the eccentric nodule.
At the ostium. But look at CSA is about 10.
Yes, lumen is open, but eccentric
nodule you forget.
There.
So the disease is mostly in the mid part of the left main, right?
Yeah, tight part is the mid left main.
Okay. So you're saying based on the thing you have to go mini crush, but then the body of the ramus is not fully. What is that? Cutting balloon?
3 to 5.
Oh no, it's too big for the DAG. No, we can go 3-0. We didn't. Yeah, we dilated it. It looks good. Okay, give me quick 3-0 cutter. And then that means we have to put a 28 stent in the DAG if we are coming up to the ostium. Right?
Yeah, sounds good.
And then we'll take a 3-5-23 from LAD to the not the ostium but mid left main. Okay?
Yeah, sounds good.
Does your IVUS agree with it?
Yeah, I agree. Exactly.
The EYE IVUS and IVU as IVUS both agree.
Yeah. Consistent.
So what we are going to do is we are going to take a 3-0 cutter to that diag here, right here. Cut it quickly. Get us a 3-0-28 stent. Go up. 16. Okay, down. Go up here. Go up, 16. So native vessel with this Wolverine, we can go all the way. We are going to 16, 18. Go up here, 16, 18. Okay, good. Down. Open the stents. Good. Go up here. Now that we are going to stent, we can go aggressive. Down. Okay, go up. Okay, down. Any questions on the decision making here?
Just to keep you encouraged, a lot of viewers all watching intently. A spurt of people joined in the last 10-15 minutes, which I've noticed. It's people who are watching it, and suddenly the case becomes more complex and they get more involved. So there is also a very specific question regarding IVL catheter, which I'd like to ask both of you when Samin and you are there.
What is this?
This is the stent.
What?
3-0-28.
Okay, so 3-0-28 going to the diag. I did not want to do bifurcation stenting, but I think based
the
on
case has
yeah.
been evolving as we go, and the need to keep calibrating
So we
your
are going to the diag first 3028 and then get me 3523 to yes, good.
Up to the ostium.
Yeah, but we cut it also. We did IVUS, that is the disease. Okay,
Samim, there is a
some diags,
very
little diags.
useful question which has come in. I think it'll help
Yes,
a
good,
lot of our
good.
viewers.
Good. Okay, give me 23.
Yes. What the question?
The
Samir?
question is from Dr. Savan Jainpurkar.
Okay.
Would be seems a Maharashtrian name. I used IVL at angulated, calcified, and balloon got ruptured, then stuck, unable to retrieve the balloon even after trying all techniques.
Yep. So no, those are some cases have been reported that compared to other balloon ruptures, they come out. IVL because of its design may not come out. So only thing I say is that you have to just bring your Godzilla or guide liner up to there.
Cut
pull.
the balloon.
Yeah. Cut the balloon and put the guide
like we
liner
have shown
Godzilla
how
up
to
to the
take the
end
root out.
and try to retrieve. But yes, IVL because of its special material and it gives trouble, may not come out. Now, question is, if you know that your small amount of particle has been left, so I would say that very simple, you then in that particular case, make sure you exclude that plastic material by putting a stent.
LAD.
Yeah.
Mistake.
And so that it does not cause any inflammatory reactions and so. But plastic is, as you know, that now a lot of plaque have a plastic. They have shown the plastic has gone into the atherosclerotic plaques very commonly.
Microplastics, yeah.
Microplastics, yeah.
Nanoparticles from
Nanoparticles, yeah. Ready?
Anu, I am so glad you decided on this because this is the real difference which will be in the case. And
question is, the main vessel you want to do longer?
Hold on. Now some dye there. Now we have 23. I can pull back because this is
a little
main is too much overlap. Yeah. Okay, now some dye.
Here we go. This is the definitive step of the case.
I'm good.
Okay, good. So which is the diagonal first?
Yeah, that's the dag.
Okay. We are going up now.
In the right, inject.
Inject, okay. Little angulated, but that's okay.
It's still a lot crush. Wait, I'm going to go in a little bit more.
Yeah. You can push a little bit in.
Okay, good. Okay, now you go up with the...
Okay, I'm going up in the diagonal. Yeah,
I think this will also address the left main.
Yeah, yep,
okay.
Yeah, of course. That main LAD we stent will cover the distal left main also, mid left main up to mid left main.
Okay, go up again.
So 16 atmosphere here.
Okay, good. Down. Okay, show me some dye. And then I take out the wire out 1 second. Yeah,
this is
truly
good.
I mean, truly amazing. I've got audience at the moment from India, from Croatia, from Trinidad, from the UK, and several from the US.
Good, right?
Yep. Going up.
Okay.
Okay.
Remarkable case for all of you. How to keep modifying the strategies, having all the options, all image guided.
Yeah, go up. No, reason I did not want to cover the osteal
to begin with.
We decided mini crush, but since our calcium modification was not the best, I did not want 2 stents at the osteal LAD left main. So I was trying to avoid that, but then once we image, I guess we had to do it.
Want to take a picture?
I think it's going to look fantastic.
You start your lecture.
All right, yeah.
Good. Okay, so now what we are going to do is recross.
Yep.
Now first I'll do the left main, proximal optimization, recross, and then
Good. So while they're getting ready for that part, let's go to our presentation aspect so that and then show the end result in the end. So let's go to the slide presentation now.
Get us a
Yeah,
408.
so this case was appropriate. Let's talk. Okay, appropriate from two medical therapy and LAD lesion. So and okay, so what I'm going to talk about quite a bit, which you have done with the intracoronary imaging, trial of stent type in high bleeding risk patient, and impact of bleeding in danger shock trial, and then updated ACS ACHA guideline of 2025. So what we got is basically the intracoronary imaging ICI in every aspect. Multiple trials in last 5 years have done and culminated into the overall acceptance of this field into our day-to-day routine, has becoming a class 1 indication. Even the recent guideline in acute coronary syndrome imaging has become the guideline number 1, class 1. Now, there is some little discrepancy in two our studies. Renovate complex PCI, when they compare diabetic versus non-diabetic, you saw the benefit of imaging, which is the height of the brown bar is half of the angiography guided PCI non-diabetic, but in the diabetic there was no difference. So they concluded, except that MI was different and stent thrombosis was trended towards lower even in the diabetic patient with the imaging. They concluded that in diabetic patient we need to do something more. Not only the treatment and also the post-procedure optimization, medical therapy, and so particularly glycemic control. Then we have the data of the IVAS ACS, which is part of the ultimate, the DEP trial. And they basically found that IVAS guided in diabetic patient versus angiographic guided has a better acute gain compared to the angiographic guided, and more importantly, at a follow-up, IVAS guided was superior to angio guided PCI. So clearly that I would say the field remains open, but imaging benefit in every aspect of our PCI, including the diabetic patient. And this basically is the central figure of that decreasing event. Second was ultra bifurcate registry, impact of IVAS for coronary bifurcation with the last generation stent, no IVAS versus IVAS, then unprotected left main versus non-unprotected left main. Real benefit is in the unprotected left main. In the non-unprotected left main, there is a stent thrombosis decreased, and which we know already with the meta-analysis by Greg Stone that stent thrombosis is half in every imaging trial, whether left main or non-left main. Then question comes, patient going for surgery or patient's high bleeding risk, what is the guideline of the 1 month DAPT? There are actually 4: Biofreedom, Resolute Onyx, Synergy, and Zymes. Those are the 4 have been approved by FDA, as well as CE mark approval for 1 month DAPT. So therefore, if you are planning a clear-cut surgery, these are the type of stent you should be using, because although other stent can be used, but these are the high bleeding risk patient, but overall it shows you that 1 month is good enough for these. Then bleeding related with a microaxial flow pump, which is the Impala in the danger shock trial. Remember, danger shock trial was cardiogenic shock trial, standard therapy versus Impala for 180 days. And you can see overall was benefit, but moderate to severe bleeding and limb ischemia was higher in the Impala group compared to the control group. And that basically the whole issue was that why that happened. And of course, no bleeding versus bleeding. They found clearly the patients who have multivessel disease, more comorbid condition, and key is the type of bleeding, which is BARC 3 to 5, which is significant bleeding, can occur anywhere. Exercise, diffuse, intracranial, pericardial, cardiac surgery, and also important was 1/3 of the bleeding occurs in the cath lab, but 50% occurred after removal of the microaxial flow pump, which is Impala, and other 20% occurred after discharge up to 180 days. So not only all occurs with the device. Now, more complex the device, higher is the bleeding number, as you can see here, and of course the bleeding associated with other complications of the sepsis, mechanical ventilations, and so. Predictors of bleeding basically was Impala use, renal replacement therapy, and escalation to VA ECMO. VA ECMO has a very high odd ratio of 5 to cause the bleeding, as you can see. Now, fortunately or unfortunately, this is the first time bleeding always predictor of the event rate follow-up, but in this particular study, bleeding did not correlate with the 180-day mortality. So that's a plus minus point, but key basically shows that once bleeding occurs, we take care of them. And this basically is that we still need to do everything possible to decrease the bleeding. And why? Because of the 14 French sheath size. Now with the 9 French device available by year end, that number will go down. So then just a little bit about the ACCHA guideline, very extensive for the acute coronary syndrome management, which they came up, very nice algorithm in terms of STEMI and non-STEMI, emphasizing that how we should be treating them separately. STEMI patients, they have the whole, the timeline and the operational flow, whether patient get a direct medical contact or patient get fibrinolytic, that all goal remain about 90 minutes and patient having chest pain up to 12 hours. And also the onset of chest pain to balloon time of 120 minutes. Acute coronary syndrome, basically that if there is not a STEMI, you need to identify what are the risks. Based on the risk, you decide whether patient should continue to be on medical therapy observation versus go for cath lab. Then very aggressive treatment in terms of the LVEF, trying to bring it down to less than 55 by combination strategy. And this is basically about the risk stratification of acute coronary syndrome patient who presenting for strategy, whether, as I mentioned, the class 1 or directly go to the cath lab, or basically manage and then you decide. Then multivessel CAD in STEMI, which has come already, that if it's not cardiogenic shock, multivessel PCI is indicated, preferably during the same hospital admission. A few studies, but if you're cardiogenic shock, you do only culprit vessel PCI and don't do all vessel. So this is very important. As you know, the cardiac rehabilitation referral after PCI, particularly acute coronary syndrome and MI, has become the marker, quality marker by the CMS, and which hospital gets punished. You get the number in the NCDR also. They expect 73% minimum cardiac rehabilitation referral. And there you talk about not only the exercise, everything, from the patient assessment, nutritional, weight management, blood pressure management, lipid management, diabetes, tobacco cessation, psychosocial, physical activity, and exercise training. And training basically is about 30 minutes, 5 times a week of the moderate training to improve overall, decrease the lower cardiovascular and all-cause mortality, reduce readmission, and cost-effective through exercise, education, psychological support, and medical optimization. And they actually have also suggested reducing the depth duration, particularly high-risk patient. So bleeding patient, you can stop after 1 month, and even otherwise, there is a point that after 3 months, 1 to 3 months, you can go to the single antiplatelet therapy, particularly ticagrelor. It's not for prasugrel, not for clopidogrel, and this actually comes out to the data from the Twilight trial. And we have to thank Roxanne Marano to get into this, making the guideline. And also that other high bleeding risk patient that you can decrease after even 1 month is necessary, and that is what I showed. Those stents that after 1 month depth can be stopped. So these are the take-home messages which I have put it together. So I sum it up. Basically, IVUS versus angiography in acute ACS, PCI in diabetic, 2 thumbs up. 1 month depth in high bleeding risk patient after most DES clearly can be done. Impact of bleeding on death after Impala and cardiogenic shock is not there, but the predictors and timing of bleeding after Impala and cardiogenic shock from the danger shock trial, we learned a lot of it. And more importantly, in 2025 ACCHA guideline, lot of emphasis on timelines, system referral, process improvement, and more importantly now with the decreasing the depth duration and incorporating imaging as a class 1 indication to improve overall outcome and survival of these patients. So now we go to our 3 questions. Following statements are true regarding the IVUS ACS trial, comparing IVUS versus angiography at 1 year in diabetic patient, lower TVF rates in IVUS versus angiography, lower TVR in IVUS, lower target vessel MI in IVUS, trend towards lower death rate in IVUS versus angio, and lower TVF without procedural MI in IVUS versus angio. The answer there is C. Lower target vessel MI was not different in IVUS versus angiography in this trial. Then following DES except one has received FDA approval for 1 month depth. Biofreedom, Resolute, Synergy, Xience, and Orsiro. And we know that Orsiro has not received the 1 month approval by the FDA. Third question, following statements are true regarding the timing, predictors and impact of bleeding in the danger shock trial, comparing Impella with the standard therapy, except Impella use had higher bleeding rate. Renal replacement therapy was one of the predictors of bleeding. Bleeding rates increase with complexity of MCS. Presence of bleeding was associated with higher mortality at 6 months, and about 50% of the bleeding occurred after MCS removal. We know that bleeding was not associated with mortality at 6 months. So with that note, our presentation is completed and claim the CME certificate. You have to go and view the webinar and then log on to this the website and complete the evaluation, which is simple 3-4 questions, and then get your credit request form with the 1.5 overall. You're getting the CME credit. So now we can ask Dr. Keeney that where are we now? You want to just show?
I like the guidelines.
Yeah.
Saying that you have to use imaging for optimization and all that, but nothing can beat the experience.
Yeah.
I was very clear. I did not want to go up to the ostium. And now we are struggling at the ostium because nothing, we are able to recross it, okay? We have post-dilated it multiple times and we cannot get a balloon across.
But we are not come to the ostium. We are only mid left main.
No, 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 no. We are talking
Oh, diagonal ostium.
yes,
I see. Okay.
Yes, yes.
Yeah.
So that was done based on imaging. If it was done without imaging, I would have stopped away from it because I knew this is what we're going to face. Okay, we did anchor. We tried all kinds of balloon, 2O balloon. The way the wire was going, I knew a 3O. Normally we say when you're doing left main mini crush, you don't need
Corsair,
to use
we
a
have
smaller
Corsair.
balloon, right?
You have the Corsair or no?
No, that's the next step. That's a
Yeah,
third.
they
We
get
tried
the
all the
Corsair.
balloons,
Yes.
but our usual
Corsair,
our
yeah.
usual 1.2 balloon is you know,
Or
back
1O
order.
balloon. 1O balloon. Sapphire.
What Sapphire?
Yeah. No, if you need a 1O balloon or Corsair.
Get us a 1.0 now.
Yeah, 1O balloon. If you want 1O balloon first. Sapphire. Good. It won't go. Yeah, that actually is the criticism of a lot of people say that of the mini crush, your balloon has ruptured in the LAD now.
No,
No, here.
it did not.
It's the blood into the
No, no, no. That was my finger.
outside. Okay. I think it's ruptured. Okay. Anyway, let's get a 1O balloon, otherwise Corsair or recross.
No, no. What I meant, we have shown so many mini crush in the live case. You can count them.
No, I'm saying
but
that-
this is because of the calcium and not being able to modify the calcium the way we had planned.
Yeah. So is it because, and it's not that it was
It's
a
not
mega
that it's
crush.
a lot of crush. Yeah.
And you have done the pot also?
Yes.
Yeah.
4.0
Even
we went up
everything
to,
we have been done.
Yes.
By the books. But that's the challenge. So every case teaches us something different. That's the life. Yeah, good. We'll be okay. 1-0.
No, 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 no,
Yeah,
no.
I
It
know,
did
I know.
not go.
I know it'll go. Go.
It will not go.
Go a little more.
Anchor.
Okay. Good.
No, so it's making that angle there.
Very sharp angle.
Yes.
Want to go balloon or no?
Which balloon? Okay, now you can go and see if it opens up.
Yeah. Okay. Go. Ruptured? Ruptured.
Who makes this 1.0 balloon?
Now this by Sapphire.
Yeah. The sapphire which... huh?
Which company?
Yeah. Hmm. No, but the company, it was supposed to be done by Orbital team before, right?
Yeah.
Yeah, Corsair. They still they have it. Hmm.
Now see, EKG changes now. Okay, guys, come down. I'm like, why EKG changes?
Okay, so now we are going with the other question is that do you put a parallel side-by-side wire and try on the different wire? Go.
No, even a wire crossing was not.
Did you cross one time or more than one time?
More than one time.
Okay, now we are going with my board question is that nothing works here. What you go Corsair, and after that you can always final answer for the exam would be laser, excimer laser. Although you can ultimately do the rota also.
I would leave everything the way it is. Looks good.
Yeah, picture-wise things look good, right? No? Why? What is happening?
There's a problem with this third wire that
There is Anu, a question for you. Could you change the recrossing strut to
They
cross?
have done it. They've done it a few times.
We done 2 times. That's what I asked earlier.
That's the first thing you do. Change the. But even that was not easy. Yes.
Go.
So, Dr.
I'm
L.
going to balloon
Rice,
a little
that's your answer to your
So we
question.
did it, yeah.
If you go to the our app, that's what we say. First change the strut.
Look, the questions are getting more and more people paying attention and
No, this has to go.
following the cases.
Okay, now we are ready for wire
Good.
perf.
Yeah, I know. Good. Yeah. Screw. Corkscrew.
That's not the thing. I think the angle of that thing is a trouble.
No, the Corsair will go. Yeah. Get an exchange length run through. Yeah.
No substitute to experience. The
Yeah.
confidence with which you said the Corsair will go.
Yeah.
Just
Okay, and then get a
remarkable.
1.5 balloon.
I hope people are
Okay. Run through
watching all this.
Make a curve. Okay, will be okay. Now your balloon will go. One side. Yeah, no, you're the funny balloon you have. They got a new special balloon now.
So
What is name? Takayu?
No, that's a balloon that did not go.
That Takaru?
Yes. Yeah. Your funny balloon can go back.
Okay.
Anu and Samin, this is a very intriguing question from somebody I have not encountered here before, Daniel Raboin.
Okay.
What would have been your threshold for using an Opian balloon for initial calcium modification rather than the standard NC balloon after failed IVL deliverability?
Good. Very good point. So I think to me, Opian balloon is very good choice. Yeah, that's absolutely correct. So particularly your IVL did not go. Opian balloon, that's what teaching is. We just don't carry it yet because of the
That is
cost.
a 2 or 12 balloon, no?
No,
2 may not go.
1.5.
We have the 1.5, no?
Yeah, new. Yeah, 1.5 you gave it. Yeah. So yes, but IVL, I mean that's a good, from teaching point of view, that's an appropriate second step. Once your IVL did not go, now I would say the other which we did not feel notice, with that lack of, we don't carry Opian balloon in our lab, is we will use a cutting balloon. But yes.
No, I did cutting in the side branch.
I see. Yeah. Okay. The Opian balloon is appropriate.
I was the side branch, and then we did the cutting balloon.
Okay. Now, just second point, the open balloon may not go also. You know, it's a double layer balloon. Many times it just does not go. If IVL did not go, I would say 70% chance that will not go either.
Very, very relevant this thing. So, Dr. Raboin asked actually where after he posed the question, he even added a word deliverability question mark, which is exactly what you're saying. That is the issue.
Oh,
Daniel,
I use an open balloon in India, and believe me, very bulky balloon.
2 or 12.
I will not. I will not be surprised that your IVL did not go and your open balloon will not go also. But yes, once you go, it's a great one. It will open up your IVL or anything which will not open because you go to 40 atmosphere with a different balloon, inflator. It's a very good device.
Lovely compliment to our discussion. It just provides the entire academic exercise. Daniel, thank you so much for pointing it out, and a pleasure. And
I think we are about done now. Once we open up with this 2O balloon, and we just finish the kissing and that end of our presentation here.
So two people, Samin, have corrected me today, and I want to compliment both of them. So starting with the Gayan Kanchana, I was reminded that she's a nurse. Now I'm Gayan. I'm not even sure if it's a man's name, or I hope I'm not making a mistake there. But either way, and Daniel mentioned that he's a CVT.
Get us a 3 of high pressure.
So just tells me that some brilliant nurses, technicians make amazing observations, sharing their tremendous expertise.
Right? Okay, down.
Beautiful. Yes.
So
and
Gayan
we welcome all.
Daniel, thank you. Yes, exactly, Samin. Welcome to all of you.
Yeah. And that is our goal and that is why we are getting 25,000 hits per month.
Absolutely phenomenal. Dr. Mahmood El Rais, what about a glider balloon to cross?
No, but crossed.
We crossed.
No, but
we used to carry glider balloon. I can tell you. We used to carry glider balloon, but again, it's a hit and miss.
Yeah, so question was the glider balloon with the 6 millimeter. We used to carry it, but overall we are not happy because the key is where your other balloon did not cross, that did not cross either. So we used to keep it. We stopped carrying it now. So I don't think
many years ago, if you go back in the live case, we have used a glider balloon.
Yep, we have used it.
Yeah, many years ago.
Yeah. So I hope you saw it. So I think what happened is that I was a little involved with some other thing, my Zoom, that after your initial little trouble you had, you go to the Corsair. Corsair will take you through. Not a problem. And that's what we did.
This is again used balloon you gave me?
No, it's a new, right?
No.
No, but
there was a new one, no?
One second.
Okay, good.
Yeah, it'll go. Yeah, good. Bring the other one now. Back. Let's do a kissing balloon so that we end
up high pressure.
Yeah,
go to the side branch, high pressure.
Just let me go first. The high pressure. Yeah, good.
No, but the exercise we did is what we teach even in the app. That is, if you recross few times, go to a different cell. Then you go with the smallest balloon. So when you're recrossing, that itself is going to give you an idea. If you recross very well first time, and this usually we see when they're in calcific lesion, and when there's calcium in the main vessel, calcium in the side branch, then recrossing. Yeah, enough. Okay. That there is no. They don't come left main. We have done everything. Okay, good.
No, but I want to go side open completely nicely.
So if you have done that, you're going to different cell, that is done. And if you are having issue crossing, that's the time itself you will know that you will need a smaller balloon to recross into the side branch. And we had a 2O balloon. 2O balloon did not go. We already recrossed multiple cells. Then you go smaller. So the smaller is 1.2, 1.0, 1.5. So you can try any of these balloons. And if that did not go, that's the time then you have to think of Corsair.
Yeah. Okay, let's take a pictures and then we are done with the last picture now. So just to say, so once you have these kind of bifurcation lesion, your first balloon after crossing should be 1.5, not bigger. 1.5. Let's take a medicine. Yeah. So 1.5, you had done that, and then you did not. Then you recrossed to the different cell just to go recapitulating what Anu just said.
No. We say first which go different cell first.
Yeah, different cell, 1.5 balloon, and then you do. Wow. All right. I think that definitely requires a clap.
And there it is. Just outstanding case. Anu, just remarkable. The case did drag on, but worth all the lessons, so many of them. I also need to thank our wonderful audience today of so many nurses, technicians, interventional cardiologists from so many countries. Looks outstanding.
So one point I want to make it very clear.
If you can warm
This
up
is
the
based on
please do some
experience.
good things.
That why I was insisting not to come up to the ostium, not to come up to the ostium of the diagonal was for this reason, that we will be struggling to recross and try to dilate, because you're closer to the left main. Okay, you have two stents, and then if you have some kind of under expansion, the risk of stent thrombosis is very high, and that is what we don't want. Restenosis we can handle, thrombosis we cannot handle, because it can rarely present as an acute event outside. And one thing we forgot, how to go back, how to image for Kiski. Oh man. Okay,
Anu,
yes.
no better conclusion than Dr. Joe from Croatia. Brilliant result. Congratulations. Lots of great teaching points.
All right. Beautiful. Thank you.
With that, we close our case today. Thank you all for joining. We'll see you during our next session on April the 15th.